Dr. Nemencio Nicodemus Jr. shall walk us through the spectrum of autoimmune thyroid disorders. A highly eminent figure, especially in the field of thyroidology, Dr. Nicodemus Jr. is a professor at the Department of Biochemistry and Molecular Biology of the University of the Philippines College of Medicine. He is a past president of the Philippine Society of Endocrinology, Diabetes and Metabolism, and a clinical professor at the Department of Medicine of the UP Philippine General Hospital. Presently, he holds several distinguished positions in these revered medical societies, namely, he is the president of the Philippine Thyroid Association, the vice president of the Philippine Association for the Study of Overweight and Obesity, and a regent of the Philippine College of Physicians. Let us now focus our rapt attention to our speaker, Dr. Nemencio Nicodemus Jr.
Good day, everyone. Before I begin, I would like to thank Dr. Michael Villa, the head of the Scientific Committee, and the officers and board members of the Philippine Society of Endocrinology, Diabetes, and Metabolism for giving me the opportunity to be part of this virtual conference. My talk for today will be on the spectrum of autoimmune thyroid disorders. In this short symposium, we will explain the risk factors that promote the development of autoimmune thyroid disease, describe the natural history of autoimmune thyroid diseases, and compare and contrast the different conditions that make up the spectrum of autoimmune thyroid diseases. Autoimmune thyroid diseases is really a multifactorial or complex disease. It is characterized by the autoimmunity against thyroid antigens that develop against a particular genetic background and is facilitated by the exposure to environmental factors. Thus, you have a spectrum of diseases that make up the autoimmune thyroid disease, which may be Hashimoto's disease on one end and Graves' disease on the other end of the spectrum. Since we are talking about autoimmune diseases, we must first identify the antigens against which the antibodies develop. And in the case of the thyroid, there are several antigens that elicit antibody response. First is the TSH receptor, which elicits TSH receptor antibodies or your TRAbs. The sodium iodide symporter, which allows the entry of iodide from the blood into the thyrocytes, also is an autoantigen with the NIS antibody as its autoantibody. The next is the pendrin, which allows, of course, the transport of iodine from the thyrocyte into the lumen of your follicle, and you have, therefore, the pendrin antibody. Next, you have the thyroid peroxidase, the enzyme which catalyzes organification and coupling, and we have the TPO antibody. And lastly, you also have your thyroglobulin, the protein that is formed and is stored inside the colloidal material of the thyroid, and then you have your thyroglobulin antibodies. Thus, you have several autoantibodies that are formed in response to autoantigens. But how are the different proteins within the thyroid gland transformed into autoantigens? It starts first with the predisposing factors, which include the genetic factors within the individual, including epigenetic factors that alter the DNA. This is then followed by triggering factors that include stochastic events in the environment, such as smoking, infection, iodine intake, radiation, the presence of stress, and even fetal microchimerism. This, together with the gender disparity and the susceptibility that comes from the genders, now makes up immune dysregulation and loss of self-tolerance. Because of this, there are autoantibodies that are formed, and because of molecular mimicry and bystander activation of thyroid-specific T cells, you now induce thyrocyte apoptosis, and thus You have now the several conditions that make up the spectrum of your autoimmune thyroid diseases. And this can be part of polyautoimmunity and can be found in aggregation, meaning that they can be found in families and therefore have familial autoimmune disease or even familial autoimmunity as overt diseases. But what are the factors that lead to the development of the opposite ends of the spectrum of autoimmune thyroid diseases, that of Hashimoto's thyroid disease and Graves' disease? There may be exogenous or endogenous factors. The exogenous factors include high iodine intake, the presence of specific infections, cytokines, and even environmental toxins. Endogenous factors that lead to the development of autoimmune thyroid diseases include the presence of our HLA class DR3, also the presence of cytotoxic T lymphocyte associated protein 4, and then you also have your protein tyrosine phosphatase non-receptor type 22, being female, getting pregnant, and having the skewed X chromosome inactivation. All of these form the factors that promote the development of Hashimoto's thyroid disease and Graves' disease. And these factors, both exogenous and endogenous, will now lead to antigen release with or without the damage to the thyrocytes, and these autoantigen are presented by the antigen presenting cells such that with the activation of your CD4 and CD8 cells, you now have autoantibodies that are formed by your B cells that can activate the complement and lead to necrosis of your thyrocytes. However, there can also be activation of your CD8 plus perforin, which leads to apoptosis of the thyrocytes, and you have death of the cell receptor and the cell ligand, and this now causes again apoptosis of the thyrocytes. These are the characteristics of your Hashimoto's thyroiditis. On the other extreme, if you activate your CD4, you now have the autoantibodies that are formed by your B cells that may actually interact with the thyrocytes in order to activate the cyclic AMP, protein kinase pathway, and also your phosphoinositide pathway that lead to the activation of iodide metabolism with the proliferation of your thyrocytes, which is characteristic now of your Graves' disease. Thus, you can see that the opposite ends of the spectrum are actually activated by almost the same pathways with different results. What are involved are, of course, your CD4 and CD8 cells together with your antibody forming cells, your beta cells. And you can see here that with apoptosis and necrosis of the thyrocytes, you have hypothyroidism on one end, and with the activation of your TSH receptor with the autoantibodies to the TSH receptor, you have now your hyperthyroidism, which is the main feature of your Graves' disease. But how frequent are these autoantibodies in the general population and, of course, in the disease process that are Hashimoto's thyroid disease and Graves' disease? You can see that the most common autoantibody found in Hashimoto's thyroid disease are your TPO antibodies and your thyroglobulin antibodies. On the other hand, despite having TPO antibodies and thyroglobulin antibodies in Graves' disease, the most frequent autoantibody will be your TSH receptor antibodies, particularly the stimulating type. See that in the general population, even if you have these autoantibodies, they are present in very small numbers in the normal population without thyroid disorders. How do we characterize these different autoantibodies? As we mentioned, The TSH receptor antibody is the most frequent autoantibody in Graves' disease. It is located extracellularly and may be found even without tissue destruction. And in terms of the duration of the antigen exposure, it may be short and low, and there can be normalization of the autoantibodies upon treatment. The action of this TSH receptor antibody is to either stimulate, to block, and even to induce apoptosis of the thyrocytes. They also have effects on the neonate in that TSH receptor antibodies can pass through the placenta and can induce transient hyperthyroidism or even hypothyroidism with delayed development of the thyroid gland of the fetus. The anti-TPO antibody is located intracellularly and it can only be accessed the antigen can only be accessed by the antibody after thyrocyte destruction. In terms of antigen exposure, there is a prolonged duration with intermediate effects, and we still see pathologic levels of this antibody even after treatment of the disease. The antibodies, however, have little action per se, but they can also pass through the placenta and can potentially affect the cognitive development of the fetus. Lastly, the antithyroglobulin antibodies are located intrafollicularly, as we mentioned, and are present in low levels in the blood. The access to the antigens may be with or without thyrocyte or thyroid gland destruction. And as far as the duration of the antigen exposure is concerned, there is a prolonged duration and high levels, and similar to the anti-TPO, there may be pathologic levels even during treatment of the disease. The anti-thyroglobulin antibody, however, has no defined action, and if passed through the placenta, it has the potential effect on cognitive development as well, similar to the anti-TPO. The natural history of autoimmune thyroid diseases follow four different stages. They all start with the genes. They have shared susceptibility genes for autoimmunity, and depending on whether they will proceed to the hyperthyroid state or the hypothyroid state, several other processes are stimulated. There are also several stochastic factors and even environmental factors that facilitate now the development from stage 1 up to the overt disease in autoimmune thyroid diseases. Therefore, it is important that we remember that there are specific genes and there are also shared susceptibility genes that interact with the environmental factors to produce a particular autoimmune disease. Let us look at one end of the spectrum, that of Graves' hyperthyroidism. There are certain Graves' hyperthyroidism specific genes, and if they interact with the environment, such as your high iodine intake, together with the gender susceptibility, and even other factors such as alcohol and smoking, you see that it progresses from stage 1 to stage 4, wherein initially there may not be any elevated antibodies at all, and the hormone levels are still normal, but the first abnormality that happens would be the presence of your antibodies to TPO. Eventually, during the third stage of this autoimmune disease, the TSH becomes suppressed, and until finally, in the last stage, not only is TSH suppressed, but free T4 is elevated, and that is all in the background of positive TPO antibodies. And as we mentioned, there are several other factors that might help and facilitate the development of Graves' hyperthyroidism, such as stress and even the postpartum state. On the other extreme, we have Hashimoto's hypothyroidism. And again, aside from the shared susceptibility genes, there are Hashimoto's hypothyroidism specific genes. And together with the stochastic and environmental factors such as smoking and even alcohol intake, you now proceed from stage 1 to stage 4 of this autoimmune disease. Similar to Graves' hyperthyroidism, the stage 1 of Hashimoto's hypothyroidism is characterized by the absence of the antibodies and normal levels of your thyroid hormones. However, the first abnormality would be the presence of the TPO antibodies in stage 2, and on the third stage, there will be an increase of your TSH until finally, on stage 4, aside from elevated TSH levels, you have a reduction in your free T4 levels on the background of your positive TPO antibodies. So clearly, you see that the first abnormality that would be present in terms of biochemical hormone levels would be the increase in the TSH, and this is because of the presence of your TPO antibodies. What are the possible preventive interventions, therefore, since we know that there are several environmental factors that lead to the development of these autoimmune diseases? Here is listed the preventive interventions that have already been seen in trials, and these include smoking cessation, the use of alcohol, the use of selenium, vitamin D, avoidance of pregnancy, and of course, avoidance of stress. And in terms of their effect on the risks of TPO antibody, smoking cessation may increase TPO antibodies, but avoidance of pregnancy may reduce the risk of TPO antibodies. Smoking cessation also increases the risk of Hashimoto's hypothyroidism, but the use of alcohol and avoidance of pregnancy, together with the use of vitamin D, may decrease the risk of Hashimoto's thyroiditis. The use of selenium has been also found in some studies to be beneficial in reducing the risk of Hashimoto's hypothyroidism. And lastly, smoking cessation, together with the use of alcohol, the avoidance of pregnancy, and avoidance of stress, all have been found in studies to reduce the risk of Graves' hyperthyroidism. But we have been talking about the opposite extremes of this spectrum, Hashimoto's hypothyroidism and Graves' disease. In reality, the spectrum is made of several thyroid diseases, which of course includes, other than Hashimoto's thyroiditis, your painless thyroiditis, postpartum thyroiditis, subacute thyroiditis, and of course the other extreme, Graves' disease. Let us discuss these five diseases that make up the spectrum. In terms of epidemiology, Hashimoto's thyroiditis is the most frequent cause of hypothyroidism and has a prevalence of 1 is to 1,000 people. Its peak frequency is in the fourth decade of age and has a female to male ratio of 8 is to 1. Painless thyroiditis occurs in 1 to 5% of hyperthyroid patients, and it has a peak frequency between 30 to 40 years old and also has a female preponderance of a ratio 4 is to 1 to males. Postpartum thyroiditis is seen in 8 to 11% of patients with autoimmune thyroid disorders. And of course, it is only found in women, but the presence of TPO antibodies during the first trimester of pregnancy increases the risk. Subacute thyroiditis has an incidence of 3 per 100,000 per year. And again, it has a female preponderance with a female to male ratio of 4 is to 1. It has seasonal incidence, particularly during summer, and is associated with the echovirus and the Coxsackie virus A and B. Finally, Graves' disease, as we know, is the most common cause of hyperthyroidism and has an incidence of 20 to 25 per 100,000 patient years. As we all know, it has a female to male ratio of 10 is to 1, and the peak frequency is between the 40 to 60 years of age. These are the different features in terms of epidemiology that differentiate the spectrum of autoimmune thyroid disorders. But how do we distinguish the different thyroid diseases other than their epidemiology? Of course, as clinicians, we must look at clinical manifestations and order certain laboratory tests, do some imaging, and finally may need radioactive iodine uptake studies. Let us look at each of these particular factors. In terms of the clinical manifestations, Hashimoto's thyroiditis will present with hypothyroidism, while painless thyroiditis will present to us with the triphase, initially hyperthyroidism, followed by hypothyroidism or even recovery to the euthyroid state in the long term. Postpartum thyroiditis has a triphasic manifestation in one-third of cases, and in another third, they may present with hyperthyroidism, and in the last third, even hypothyroidism. Subacute thyroiditis has a prodrome of non-specific symptoms and may present to us with the triphase, similar to the painless thyroiditis. The thyroid pain, however, is a very important presenting symptom. Finally, Graves' disease, as we know, manifests with hyperthyroidism, goiter, ophthalmopathy, and of course, dermopathy. These are, of course, the very important characteristics and criteria for Graves' disease. As we mentioned, painless thyroiditis, postpartum thyroiditis, and subacute thyroiditis may present to us with triphase, with an initial hyperthyroid state characterized by elevated serum T4 and reduced TSH. Over a period of weeks to months, you may have a hypothyroid state wherein there is now the reversal, with your TSH being elevated and your T4 being reduced. And in some cases, such as the painless thyroiditis, they may resolve and become euthyroid with months or even years. How about laboratory findings? How do we distinguish these diseases? Hashimoto's thyroiditis, painless thyroiditis, postpartum thyroiditis, subacute thyroiditis, and Graves' disease also, of course, differ when it comes to the T4 and TSH levels. As we said, because Hashimoto's presents to us with hypothyroidism, they may have high TSH levels with low FT4. And also, we know the presence of TPO antibodies is the main feature of your Hashimoto's thyroiditis. Painless thyroiditis may have different TSH and FT4 levels depending on the phase, but up to 50% of patients will present with TPO antibodies. The CBC does not present with leukocytosis, and the ESR is not accelerated with a negative CRP. Postpartum thyroiditis may have similar laboratory findings as that of painless thyroiditis, with more TPO antibodies present in up to 85% of patients. Subacute thyroiditis, on the other hand, because of its triphasic nature, also will have different TSH and FT4 levels depending on the phase. But here, the CBC shows leukocytosis, and the ESR is accelerated, and the CRP is also elevated, with TPO antibodies being found in less than one-fourth of the patients. Thus, you see here the differences between your painless thyroiditis and subacute thyroiditis in terms of the CBC, the ESR, the CRP, and even the presence of TPO antibodies. Lastly, Graves' disease, as we know, presents to us with hyperthyroidism with low TSH and high FT4 or even FT3. And also, very important now is the presence of your TSH receptor antibodies. The importance of these antibodies is highlighted with the publication just last year by Dr. Kahali of this diagnostic approach to hyperthyroidism, where, aside from low TSH, he specifically mentioned in his algorithm that we look at the FT4 and FT3, and the presence of the TSH receptor antibodies will now make us give a diagnosis of Graves' hyperthyroidism. And so indeed, the presence of these autoantibodies will now be very important for us to make a definitive diagnosis of the autoimmune Graves' hyperthyroidism. In terms of imaging, Hashimoto's thyroiditis will present to us with enlarged or shrunken thyroid gland, but they tend to have diffuse features and hypoechogenic features. And if the nodule is present, it is important that we do a fine needle aspiration biopsy. Painless thyroiditis presents to us with heterogeneous, hypoechogenic, and even normal-sized thyroid gland. Postpartum thyroiditis presents almost similarly as painless thyroiditis, while subacute thyroiditis presents with enlarged but diffusely echogenic ultrasound findings. Lastly, Graves' disease also presents with a diffuse enlargement and echogenic thyroid gland on ultrasound. In terms of the radioactive iodine uptake, Hashimoto's thyroiditis, painless thyroiditis, and subacute thyroiditis all present to us with low uptake. Of course, we know that in the postpartum state, radioactive iodine uptake is relatively contraindicated during breastfeeding. In Graves' disease, of course, you have an increased RAI uptake. In terms of treatment, since Hashimoto's thyroiditis presents to us with hypothyroidism, thyroxine supplementation is very important and is crucial. Painless thyroiditis may just need beta blockers, particularly during the phase of hyperthyroidism. Postpartum thyroiditis, in one-third of the cases, may have similar management such as post-painless thyroiditis in terms of giving beta blockers, and propranolol may be the best beta blocker to give postpartum thyroiditis, while thyroxine supplementation may be needed if there is breastfeeding or if pregnancy is being planned. Subacute thyroiditis will need nonsteroidal anti-inflammatory drugs to control the pain, and these are your first line drugs. And the second line drugs include glucocorticoids for the control of the pain. Lastly, Graves' disease, as we know, must be treated with antithyroid drugs plus the beta blockers. In some cases, we may need to give radioactive iodine treatment, and in other cases, there might be a need for thyroidectomy. And so, my dear colleagues, with this short discussion, we were able to study and discuss that autoimmune thyroid disease is a result of both endogenous factors that may include genetic and epigenetic factors, and even exogenous factors that include stochastic events and even gender disparity, and all these factors lead to autoimmunity. That autoimmune thyroid disease has four stages, and these stages are characterized by changes in the TSH, the FT4, and the presence of the TPO antibodies. And lastly, the spectrum of autoimmune thyroid disease that includes Hashimoto's hypothyroidism, painless thyroiditis, postpartum thyroiditis, subacute thyroiditis, and Graves' disease differ in their presentation, diagnostic findings, and treatment. And as a clinician, it is important that we are aware of these differences so that we can give the appropriate treatment. Thank you very much.
The Philippine Society of Endocrinology, Diabetes and Metabolism Incorporated awards the Certificate of Appreciation to Dr. Nemencio A. Nicodemus Jr. in grateful appreciation for graciously sharing his valuable time and endeavor as speaker during the 2021 PSEDM Virtual Annual Convention themed Hope, Health Optimization and Progress in Endocrinology this 18th of March 2021. Virtually signed by Dr. Michael Villa, the Vice President of the PSEDM, and Dr. Jeremy Jones Robles, the President of the PSEDM.